Hello, I'm Dr. Olivia Agnes D. Mejia, a member of the Department of ENT and Hospital Research Unit, and I'm here to give an introduction to evidence-based medicine. This lecture will be based on the book titled Painless Evidence-Based Medicine, Second Edition, by Drs. Antonio and Leonila Danz and Dr. Maria Asuncion Silvestre. Half of what we learn in medical school is wrong. We just don't know which half. This statement and variations of this statement have been echoed through different fields. And the reason behind this is because science evolves too fast that by the time scientific developments reach our textbooks, some new discovery is already likely being recorded. It is hard to keep up with the literature, especially in this day and age where the outlets of information are so, if not too many. There is also a gamut of publications, both in libraries and the web, that efficiently sifting through the information is a daunting task for most people. Traditionally, clinicians were trained to look to authority to resolve clinical dilemmas. Such authority are in the forms of the textbook, an expert, or a senior consultant. Evidence-based medicine equips physicians with strategies that allow tracking of the latest publications and critical appraisal of these studies. The definition of evidence-based medicine, or EBM, has been phrased in different ways. But in the book Painless Evidence-Based Medicine, they define EBM as the following. I quote, EBM is a systematic approach to the acquisition, appraisal, and application of research evidence to guide healthcare decisions. I would just like to emphasize the phrase systematic approach. This allows for a logical and efficient method that makes the evidence less overwhelming, and it also allows you to check if you are doing it correctly. Evidence-based medicine teaches us three skills. First would be acquiring the evidence. Second would be appraising the evidence. And third would be applying the evidence. Acquiring the evidence can be done in two ways, either by active searching or just browsing. An active search is driven by a clinical problem. It is more direct and likely leads to better data retention because a specific clinical dilemma drives your search and the information you are looking for is specific. In browsing, data is just chanced upon. The acquisition of evidence begins with asking a focused clinical question, where the population of interest, or P, the exposure in question, or E, and outcome expected, or O, are clearly stated. For example, among elderly patients with hip fractures, does early surgical intervention affect risk of death? In this question, P, or population, would be elderly patients with hip fractures. The E, or exposure, would be early surgical intervention, and the outcome expected would be risk of death. The acquisition of evidence also requires an effective literature search. The most popular medical literature databases, such as Medline, classify their articles based on P, E, and O. Fairly recently, they have also been classified according to study design. There is a separate video of how to do an effective literature search in the ITRMC virtual classroom on YouTube. Acquiring the evidence ends in effective retrieval of the data. This may be done by downloading free full-text online articles. It may also be done by requesting help from colleagues who or companies that have access, and another option is writing directly to the author. The second skill of EBM is appraising the evidence. This is important because not all studies that make it to publication are relevant or correct. The words like, quote-unquote, significant difference are almost like buzzwords to the average clinician, but such findings are not always relevant or correct due to flaws in the sample size, study design, or methodology. This is why critically appraising the evidence is an important skill to learn. In appraising the evidence, we first appraise directness. This is done by asking, how well does the study's PEO correspond to your PEO? For example, if your focused clinical question is about elderly patients with diabetes, an article on neonatal diabetes would obviously not be applicable. Appraising directness is a good way to weed out irrelevant articles. Appraising validity looks into how close the study results are to the truth. Studies cannot be classified as perfectly valid or completely invalid. The gray area is huge and studies can be flawed. An important tool in appraising validity is understanding the hierarchy of evidence. This allows you to get the best possible evidence for your focused clinical question. This slide shows the hierarchy of evidence, and as you can see, expert opinion and case reports and case series are at the bottom in terms of evidence. Appraising the results includes understanding concepts like relative risk reduction, number needed to treat, likelihood ratio, odds ratio, and hazard ratio. Results can be considered as the numerical expressions of effectiveness, accuracy, causal relationships, and prognosis. The third skill of evidence-based medicine is applying the evidence. So here, you first assess applicability. This looks into the finer details such as socioeconomic and biologic differences to assess if the study's results can be applied to your patient or population. The question you ask here is, will this work on my patients? You also look into individualizing the results. This is both a science and an art, wherein you present the magnitude of effect on an individual while allowing for shared decision-making and incorporating the individual's values and preferences to determine the trade-offs between benefit, risk, and cost. In summary, evidence-based medicine is a systematic approach to the acquisition, appraisal, and application of research evidence to guide healthcare decisions. A systematic approach to acquisition of evidence allows us to filter through the overwhelming amount of data in order to be able to efficiently keep up with the literature. Critically appraising the evidence involves thorough assessment of directness, validity, and results. Application of the evidence involves skills in assessing if the evidence is applicable to our patients and if the results may be individualized.